and TEG and ROTEM to manage, for example, patients with dengue or after snake bite. So acquired coagulopathy can cause not only bleeding, but also thrombosis in various guises. Again, I think, the ISTH definition of DIC also focuses on the contribution of the endothelium and the microvasculature, not only in amplifying the immune response, but also in activating the clotting. And as we'll come to see when I get on to COVID, there's also, further interesting work that has been done in this setting. And again, we know that the impact of the microthrombi can result in multiple organ dysfunction syndrome. And the more organs that are involved, the worse the outlook. And really, this figure is not dissimilar to the figure that I use when I talk about COVID-19 being a multi-organ disorder. And certainly, the picture that we used to see in particularly the first wave of COVID-19 patients. So DIC is associated with a very significant rate of both bleeding and thrombosis, and is an independent predictor of organ dysfunction and mortality. Again, so there's a very nice article by Julie Helms from Strasbourg in intensive care medicine this year on management of coagulopathy in critically ill patients, with some particularly nice figures. For example, this one showing the kind of clinical conditions that are frequently associated with coagulopathy. I mean, the big hitters are, clearly sepsis, cancer, the obstetric setting, trauma, in tropical countries, heat stroke as well. And clearly some hematological malignancies also strongly associated with coagulopathy. And again, there's an emphasis on DIC with two main clinical phenotypes, one with more of an emphasis on bleeding, and the other with more of an emphasis on thrombosis. And again, this is a nice figure, showing that, for example, in cancer patients, both thrombosis and fibrinolysis can be a problem. In acute myeloid leukemia, the fibrinolytic phenotype, of course, predominates. And in trauma and peripartum bleeding, it is a combination of the phenotypes, and really that is an area in which, for example, antifibrinolytics like tranexamic acid come into their own. And sepsis, again, often leads to a highly thrombotic phenotype. Again, a large proportion of critical care patients are thrombocytopenic, and the prevalence on admission to critical care is very high. I'm sure, in some of your patients in Sri Lanka, for example, with dengue or malaria, I mean, this is a big factor and is a marker of illness severity, and is linked very clearly in the evidence to a worse mortality. Again, there's many potential causes of thrombocytopenia with increased consumption or destruction of platelets, as well as decreased platelet production and increased sequestration. And also there's been data in existence for decades that thrombocytopenia is a poor prognostic marker in critical care patients, and day 4 platelet count particularly is a useful prognostic marker. So anticoagulants and bleeding, again, it's for us, this is probably the most common cause of serious bleeding that we see. Clearly with warfarin, we've had measures to monitor warfarin in the form of the high INRs and to reverse warfarin using vitamin K as well as prothrombin complex concentrates for a long, long time. And the PCCs are immediate acting. Vitamin K takes about 6 hours to kick in. And again, with unfractionated heparin, for many years, we have had protamine sulfate as an antidote. With the newer anticoagulants, I think it is a particular problem. And I think it's very important when patients present to know, if possible, when they took their last dose of anticoagulant. And clearly, because now the direct oral anticoagulants are, the anticoagulant of choice in most patients for the treatment of venous thromboembolism as well as for stroke prevention. And so we have, for example, at King's 24-hour assays for the direct oral anticoagulants. Again, we generally... Sorry, can people mute? Yeah, would people mind muting? Thank you. Yeah, so there clearly are modern antidotes available for the direct oral anticoagulants, but our current pathways utilize PCC as a mainstay. There's this new decoy molecule, the andexanet, available for the anti-10A inhibitors, but it's very, very expensive. It costs about £15,000 per dose for us and is associated with a very high rate of rebound thrombosis, in the early studies, about 10 to 20%. So I don't think it's going to be licensed by NICE anytime soon. So just for this introductory part of my talk, coagulopathy is common, and really there's a delicate balance between the risk of thrombosis and bleeding, and you would manage the coagulopathy according to the underlying condition. And clearly, no talk that I give goes without mention of thromboprophylaxis, because critically ill patients are at particularly high risk for both thrombosis as well as for bleeding. And generally speaking, the thrombosis risk predominates, but in the cases of high risk, like neurosurgical patients with intracranial bleeding or post-trauma patients, we may prefer in the initial stages to use mechanical measures like intermittent pneumatic compression, but otherwise the mainstay of thromboprophylaxis for most patients is low molecular heparin. So there is a delicate hemostatic balance in critical care patients between thrombosis and bleeding, and often, for example, in sepsis, with a consumptive coagulopathy and a consumption of both platelets as well as procoagulant and anticoagulant factors, the balance shifts towards clotting in the microvasculature and not bleeding. And we have, one of our particular research interests is clotting in liver disease. And again, in patients with liver failure as well as with chronic liver disease, if you use TEG or OTEM, you find, the balance is more towards thrombosis than bleeding, despite very deranged clotting indices, which is why the ISTH guidance is not to treat the numbers themselves, but to treat the patient. And again, I think in all these areas that I've mentioned, like trauma or in the postpartum setting, the massive hemorrhage protocols, I think the use of the viscoelastic assays, TEG and ROTEM, have really been very, very useful in progressing care of these patients. So I think that is by way of introduction before I go on now to focus on COVID-19, which nearly 3 years on, 700 million coronavirus cases globally, over 7 million deaths. In the Sri Lankan situation, we are talking about nearly 700,000 confirmed cases and a very substantial number of deaths. Again, thrombosis was a very prominent part of the first wave, and also to a certain extent with the second wave. But I think with the Omicron and the newer variants, and also the improving holistic care of COVID-19 patients, thrombosis is much less of a feature. So what are the lessons that we have learned from the COVID-19 pandemic? I think before I get stuck into the particular focus on the COVID coagulopathy, I think these really have been extraordinary times. There's been so much misinformation, a lot of interim data tweeted, and people very eager to act. So I think there have been many myths regarding the origins of COVID, the manifestations of COVID, and the ideal treatment. There have been, certainly with the first wave, big departures from evidence-based practice. And all was not always what it appeared. You were getting papers in New England Journal and other prestigious publications that were subsequently retracted. So, but equally, I think it has been an extraordinary time scientifically, truly miraculous, I think, with how the agile and collaborative research strategies have helped improve care and accelerated research, and we have seen very swiftly the introduction, for example, of dexamethasone or IL-6 inhibitors or remdesivir. And of course, I think vaccines have been a big triumph in helping prevent disease and reduce disease severity. And I think the kind of incremental improvements in the care, like, for example, proning and better hydration and all the rest that we have done, have helped improve outcomes. And unfortunately, there was also the mischief, for example, in the form of the unexpected adverse effects of the adenoviral vaccines, for example, were caused a big problem and very unexpected and unusual manifestations, which I will describe towards the latter half of my talk. So really, there have been many false dawns as well. The hydroxychloroquine and azithromycin, and I did a lot of work with Indian Society of Critical Care Medicine over the course of the first 3 years, and people were doing crazy things, and even the average mildly affected patient in India was on this cocktail of 10 different highly speculative drugs. But I think there's no doubt that, availability of dexamethasone or tocilizumab or remdesivir have really helped transform disease. There have been over 3,000 RCTs, both big and small and very heterogeneous in their design, and over 75 just investigating heparin in COVID. And I will go on to describe these during the course of my talk. And again, I think these COVID trials were very, very good at sorting different personality types, from the very heroic early adopters who wanted, after seeing one tweet about a trial, they wanted to go in with a new intervention, and there were the more conservative brigade who wanted to actually see the paper published rather than just go on the tweet or the preprint. So I think very, very early on from Wuhan, there was the information on the COVID-19 associated coagulopathy in nearly half the hospitalized patients with COVID. There's a very marked elevation of D-dimer and the acute phase proteins. And interestingly, this could be differentiated from the typical DIC in that the platelets and the fibrinogen were not usually that low. The fibrinogen was often quite high, and the platelets used to be quite well preserved. There was also a high rate of lupus anticoagulant positivity in these patients. And really, there's early evidence that D-dimer increases were linked to both mortality as well as higher odds of critical illness. And thinking back to those days, there was an explosion of D-dimer testing. And in the UK, we were very near running out of D-dimer kits, because D-dimers were being used to direct treatment both in hospitals and also in the community. And really, I think once things settled, I think if a patient was being hospitalized with COVID, if they were bad enough to be hospitalized, there's certainly a case for testing the D-dimer on admission to hospital, and then maybe serially on critical care on a daily or alternate daily basis. But really, I think what we saw widespread D-dimer being used to anticoagulate people in the community really was not evidence-based. And thankfully, it all has settled down over the past year or two. So again, the COVID-19 coagulopathy has these kind of characteristic features, and partially overlaps with the coagulopathy that we see in sepsis or DIC or in hemophagocytic syndrome and in microangiopathies as well as antiphospholipid syndrome. But in many ways, it does not perfectly match these coagulopathies. The incidence of DIC in COVID patients is low. In some of the studies, it's as low as 1%, and often becomes a feature in severe COVID in the end stage. But in kind of large cohort studies, it was about 8% in COVID compared to about 30% in sepsis. So again, the platelet count can be normal or slightly low initially. D-dimer is markedly elevated. Again, there's theories, as to what causes this, whether it's the alveolitis and alveolar macrophages secreting plasminogen activator, and also direct infection of the endothelial cells via the ACE2 receptor can lead to a massive release of plasminogen activators and this kind of huge mismatch in the D dimers. So it is, unlike DIC, which is a consumptive process, which with the natural anticoagulants being consumed and fibrinolysis in COVID-19 coagulopathy, it's not a predominantly consumptive coagulopathy. And again, the data showed very, very good correlation, unsurprisingly, to inflammatory cytokines like IL-1 beta and IL-6. So again, this concept of immunothrombosis or thromboinflammation became very fashionable. I suppose we had previously encountered this in maybe some cancer-associated thrombosis and also in antiphospholipid syndrome. And it was a combination of COVID-associated coagulopathy as well as endothelial dysfunction. So the activation of the host defense leads to inflammation and subsequent activation of the coagulation as well as endothelial injury. We know the receptor for viral adhesion is the ACE2 receptor in the epithelial and endothelial cells. And so several pathways are involved, the contact and complement pathways, there's endothelial injury, and then the neutrophil extracellular traps, the NETosis. Again, some of the more contemporary studies look at, trying to inhibit the nets, for example. So all of this results in a combination of microvascular and macrovascular thrombosis. So this is thromboinflammation. And again, there were a lot of early studies in March, April time from China, which showed that coagulopathy predicts worse outcomes in critical care patients. And also the idea that heparin might have a role in improving outcomes came into being, but this was a very biased early study with, only 20% of the patients received thromboprophylaxis. So there were significant concerns around selection bias of these studies. But again, this idea that D-dimer is linked to worse outcomes and worse mortality, and that could the use of anticoagulation mitigate that. Again, there were large observational studies from New York at the time that hinted that anticoagulation, whether prophylactic or therapeutic, might help improve survival. So there is clearly the main phenotype in COVID seems to be that of thrombosis, but bleeding can also be a significant issue. This was an early multi-center retrospective study of 400 hospitalized patients, which showed an overall bleeding rate of 4.8% and major bleeding rate of 2.3%. And they found that D-dimer was predictive not only of thrombosis, but also bleeding. So subsequently, there was a large systematic review by David Jimenez that showed that the overall bleeding rate in thousands of patients was about 7.8%, and the major bleeding was about 4%, but that included cohorts of patients on intermediate and therapeutic dose anticoagulation for thromboprophylaxis. There's also this more recent study in the BMJ, which is based on Swedish National Registry data in nearly 1 million patients who were positive for COVID. And they showed a 5-fold increased risk of DVT, 33-fold increased risk of pulmonary embolism, and 2-fold increased risk of bleeding. And all of these risks, as we can see, the severity were worse in patients admitted to ICU. And interestingly, the risks extended out for many, many months. For pulmonary embolism, about 6 months after the original infection, for DVT for 3 months, and for bleeding for 2 months out. And again, the majority of these patients were not on anticoagulants. So, we are still seeing a balance between thrombosis and bleeding, but I think the predominant phenotype that we encountered in these patients was that of thrombosis. Again, this picture, I'm sure, is very familiar to many of you. It's a classic COVID lung. And really, thinking back to April and May 2020, we were seeing 3 times as many cases of pulmonary emboli as we would usually see at King's. So King's, where I'm based, looked after over 10,000 patients with hospitalized with COVID. We had 120 critical care beds, and amongst, I think, the top 2 outcomes in the country for hospitalized COVID-19 patients. So there was evidence that thrombosis is also linked to a 75% increase in the overall mortality. Whether that is down to the thrombosis in itself or is a marker of disease severity, we don't really know. So I think what we do know is that certainly in the first wave, and the second wave perhaps as well, of COVID, we saw an extraordinary burden of thrombosis affecting both large vessels and small vessels, as affecting both veins and arteries. So I think the pulmonary thrombi were the most common manifestations, which was a combination of the usual embolization from DVTs in the leg to in situ thrombosis, which was both kind of microvascular and macrovascular. And we saw also arterial thrombosis, stroke in about 3% of patients, and myocardial infarction in 9% of patients. And we had, COVID toes, COVID fingers. The photograph on the right is one of our mildly affected patients with Palmer digital vein thrombosis. So again, these clinical manifestations of thrombosis were very much front-loaded, particularly for stroke and myocardial infarction to the first fortnight or so, but I think with venous thromboembolism stretched out to 4 weeks and beyond. So there were also many, many early studies from critical care patients. Again, this is from Julie Helms, in which to those of us who looked after these patients, this is a very, very recognizable narrative. About 15-20% of these patients had pulmonary embolism despite the standard use of thromboprophylaxis. Again, virtually all the patients on renal replacement therapy were having issues with clotted circuits. We were getting thrombotic occlusions of ECMO. and a lot of line-related thrombosis as well. And in part, I think these problems also were related to the early perceptions that the lungs we were seeing in COVID were in part due to fluid overload. So we were tending to dry these patients out instead of hydrate them. So I think that particularly contributed to the issues with, we were running out of renal circuits, replacement circuits, and more patients were being switched to peritoneal dialysis, for example, at that time. But thinking back, to spring and summer 2020, this, were the very typical thrombotic manifestations in critical care units all around the world. And again, so with some of my colleagues at King's, we wrote one of the early papers for Kidney International, highlighting this issue with acute kidney injury in COVID patients, likely due to microvascular thrombosis in the kidneys, and very, very common in those that were critically ill. And we suggested potential modifications for COVID-19 patients, including use of citrate or higher doses of low liquid heparin, and using anti-10A monitoring, and using alternative anticoagulants like argatroban. Thankfully, this is all an issue from the past, and certainly we have very many fewer COVID patients in hospital. We're a 1,000-bedded hospital. We had at our peak about 800 of those beds occupied by COVID patients, and now we have about between 20 and 50, because COVID is going up in the community again. But these the newer strains are much milder, as we know. So there's an increased incidence of venous thromboembolism in COVID-19. And again, the overall VT prevalence was about 14%. Again, a lot of those were pulmonary embolism, and this was 3 to 4-fold higher than in sort of comparable non-COVID patients in ICU, and certainly compared to what we used to see with SARS or with H1N1 influenza. So really, this was despite the use of standard thromboprophylaxis, which is why we were all thinking that we needed to use intermediate dose anticoagulation, because there were high VT rates despite the standard prophylaxis. So there was certainly in the UK and in the US a move towards using intermediate dose low liquid heparin in critical care patients. And really the anticoagulant of choice was low liquid heparin, because it's for all the evidence for thromboprophylaxis in medical and surgical patient lies. It's better absorbed, minimal drug interactions, and there were these potential mystery antiviral and anti-inflammatory effects. Again, there was a lot of work done around epidemiology in COVID. This was, again, one of the early papers from our group after the first 1,500 odd patients with COVID-19. We found that about 3.5% of ward patients and 16% of critical care patients had pulmonary embolism. Again, about half of them were in the segmental and subsegmental vasculature, highlighting the contribution of the in situ thrombosis that I had mentioned. And another controversy at the time was whether we need to be giving thromboprophylaxis post-discharge. again, one of my colleagues, Lara Roberts, showed that post-discharge venous thromboembolism was not really a big problem compared to our historical data in medical discharge. So post-discharge VT is not a big problem. And really, the pre-COVID RCTs did not provide a convincing case for extended thromboprophylaxis in medical patients. Because if you look at trials like the APEX trial with Vitrexban, the number needed to treat to prevent a clot was about 176, and the number needed to harm was 60. So really, we don't do extended prophylaxis even now in the majority of medical patients. But I think there's this new concept of, maybe things are not absolutely straightforward and it's not a one-size-fits-all approach to tackle immunothrombosis in COVID-19. Because as the thrombosis and the bleeding risk alters during the natural history of the admission, is there a rationale for adjusting the intensity of anticoagulant? Because maybe, in advanced disease, you are less able to affect the pathology, and it's really too late. So do we need to adjust anticoagulation to the degree of inflammation as well as bleeding risk? So here we came into these multi-platform studies of REMAP GAP, ATTACK, and ACTIVE, which looked at using therapeutic doses of low liquid heparin. And unusually, the main outcome was not venous thromboembolism, but organ support-free days. And again, there were these interim results tweeted in the winter of 2020 that therapeutic anticoagulation in critical care patients did not reduce the need for organ support and caused harm, whereas in the moderately ill patients on the ward, that there seemed to be some superiority in terms of outcomes. So again, this resulted in the change in the national recommendations in the UK that maybe we should be considering therapeutic low liquid heparin for those with moderate disease, and also not to base the prophylactic dosing on the level of the D-dimer. But there were two major flaws in that the control group in these multi-platform studies were non-concurrent patients. The other were that in the critically ill patients, 22% of those in the therapeutic group did not receive therapeutic dose anticoagulation, and 50% of those in the control group received intermediate dose anticoagulation. So when we look at these studies as a whole, there are kind of major flaws and large heterogeneity in terms of the chosen outcomes. But as I said, this resulted in a kind of polarization in that there were some people who immediately switched to giving moderately ill patients therapeutic doses of anticoagulation, and others like ourselves who continued to use standard dose of prophylaxis because we were not convinced by the data at the time. Again, there was a study in critical care patients of intermediate dose anticoagulation, which was underpowered, that did not show any benefit. So these were the RCTs at the time. The ones in green had the so-called kind of positive results, and showing that in moderate patients that there might be some benefit in terms of reduced need, a 4.5% absolute reduction in the need for organ support. So number needed to treat was, I think, 25 to reduce organ support and over 100 to improve survival. So again, I think now this is all very much in the past, and there are still modern day publications looking at this, but I think the current recommendation would be for standard dose prophylaxis. So again, aspirin and antiplatelets do not improve survival, and the current guidelines is to use standard dose thromboprophylaxis in hospitalized patients with COVID. So really, anticoagulation was an important part of the armamentarium, but was not enough in itself. And so I think there were multiple strategies: the use of antivirals, the use of immunomodulators as well made a big difference. And I think the overall improvement in hydration as well as the proning helped improve the outcomes. And clearly, prevention and the use of millions of doses of vaccines worldwide had, completely transformed the picture in COVID. But then comes this very, very unusual and unexpected phenomenon of vaccine-induced thrombosis, thrombocytopenia. Again, I think we saw one of the first cases to be described at King's, when a healthcare professional, because they were prioritized to receive vaccine, received the AstraZeneca vaccine, which is the adenoviral vaccine, which is also the Serum Institute vaccine in South Asia. So he presented about a week after receiving the vaccine with sagittal sinus thrombosis, which within hours became very hemorrhagic. And the young man, I think aged about 32, had died within about 24 hours. So we saw over 400 cases of vaccine-induced thrombocytopenia, thrombosis. A very substantial number of them had cerebral sinus thrombosis. Others had splanchnic vein thrombosis, and some had just, usual DVT and pulmonary embolism. And there was a very high case fatality rate. So the kind of hematologists locally, once they had seen quite a few cases, got together, and we were meeting on a daily basis and to develop this VIT. And the first person who actually tested these patients for the antiplatelet factor 4 antibody was Andreas Greinacher in Germany. And, the first description of VIT, along with the serology, was from Norway and Germany, and soon after from Marie Scully at UCL in London. And then we developed this concept of, the history of the vaccine, the thrombosis, thrombocytopenia, and the positive serology. Excuse me, I've just got an urgent call. I'll just rejoin you in literally 30 seconds. Thank you. So sorry about the interruption, but I'm happy to be on call today. So I've just got one of my colleagues to cover that call. So really, this concept of VIT, which seemed to predominate in younger patients, and I know from discussions with colleagues in Sri Lanka, you were also seeing it in Sri Lanka, came into being. And we very swiftly developed a modus operandi as to how to manage these patients with a combination of intravenous immunoglobulins and then basically, doing what we did in heparin-induced thrombocytopenia. Though since heparin wasn't part of the epitope, there's no clear rationale for avoiding heparin. And, I'm aware of many cases in which heparin was used successfully. But within months, we had stopped using the AstraZeneca vaccine and we did not see any further cases. Again, it's a very difficult tension because in population health terms, giving the vaccine is no doubt, benefits the population, but at the cost of maybe adversely affecting 1 in 100,000 of the population. So where are we now? So thrombosis does not seem to be an issue with the current COVID-19 variants. And I think we should use standard risk assessment and thromboprophylaxis approaches. We no longer see VIT because we don't use the Oxford vaccine anymore. It would be interesting to see if it's still an issue for you. So now I think the COVID, generally speaking, is a much milder disease. So the question is, has the thrombosis saga in COVID-19 come to an end? Not quite. There's this recently published study in Nature Medicine in which they looked at about 1,900 adults hospitalized with COVID and identified two distinct biomarker profiles which might be linked to the so-called long COVID. The first profile linked elevated fibrinogen relative to CRP with cognitive deficits. And the second profile linked elevated D-dimer relative to CRP to fatigue and shortness of breath. So this is an interesting recent publication. Don't quite know what it means yet. So in summary, what are the lessons we have learned from COVID-19? Clearly, there's the COVID-19 specific knowledge about how to look after inpatients with COVID, not to generally give post-discharge prophylaxis. And we've kind of applied this kind of knowledge of anticoagulant and anticoagulant dosing to general VT prevention, precision use of anticoagulants. And then, there are wider lessons and food for thought, in that certainly I think this clinical research trial design went forward by leaps and bounds. And there was this tension between, responding immediately or waiting for the proper paper to be published, for evidence-based practice. And really, I think it highlighted, the power of the united voice in advancing medicine and research aims during the crisis. So I will stop sharing at that point and happy to take